allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay, you can sit down.
You may sit down now. Hey, if you want to stay standing, you can do that too. Any public comment? No public comment. Want to say hi to Shirley. Welcome to the team.
Thank you.
Has everyone met Shirley already?
No, I'm Kent. I'm that person.
Hi. Nice to meet you.
I'm Mr. Farrell. Okay. Oh boy. We're in trouble tonight, aren't we?
It's a pretty polished way of looking at things.
John Shine will be a little bit late, so we'll just go ahead and start the line. First item on the agenda is approval of the consent agenda. Did you guys have a chance to read the minutes? Okay.
Go ahead.
So, well, I'll move we approve the consent agenda.
Second.
Second, okay. Moved and seconded to approve the consent agenda, and the November calendar is here. All those in favor?
Aye.
Okay. So, boy, we're going right along, Ed.
Yes, sir.
The financials.
All right, so this is the financial report for August 2022, the second period of the 12-period year. Start with patient counts for acute was 316, an increase of 19 over the previous year. Clinics, 2209, an increase of 214 over the previous year. Other outpatient services, 5256, a decrease of 529 over the previous year, which actually equals about 300 labs and 130 less in rehab, because there was like a transition period for rehab where some folks were leaving, they were getting new folks in.
In this year?
Yes.
When you say folks, you mean patients?
No, they're always full. They have 70, 80 a day, so they're occupational therapist, I think, and a physical therapist, and a pediatric therapist. The same thing.
Occupation and speech.
Yes.
So you were down 3.
Yes.
Okay.
But you'll see it pick up in the following month. Next slide.
We are still struggling to find speech therapists.
Okay.
Is there a high demand in Lake County for a speech therapist?
It isn't that there's a high demand in Lake County. There's a demand all over the country. And so where there's a demand, there isn't enough supply.
Yeah.
All right, gross patient charges for August, it was 4.4 million, an increase of 242 over the last year. And we're staying at budget or above so far, so that's a good thing. Next slide. Collections for August was 3 million even, an increase over last August of 10,000, which is not big enough thing, so we're striving for more.
We're still lagging on the collection, right?
Yes, a little bit, and some of it is Medicaid takebacks to the tune of about 750 grand, and as well as Medicare takebacks, and it's kind of like a true up year to year. But in October we're 100% clear. So
Okay, so we'll have a better ratio in October.
absolutely,
Okay.
much better. Days cash on hand. For August, we had cash on hand of 17 days. This is 71 less than this time last year. The big portion of where that cash went is the Medicare took back 722,000 in August, 456 in September, and only 99 is owed now. So.
And they've taken that on.
Okay, they've taken that, and in September, we'll book that 500,000 in?
Yep. As well as the 500,000, as well as the 456 they take back, so it's kind of a net plus 50. But I'll get into that definitely on the cash flow statement. I try to do an abbreviated cash flow statement just to keep everybody in the loop. Monthly net income for August at 4.4 and gross revenue, less revenue deductions of 1.3 million, which is, once again, too high. And that's what we're working on. Less expenses of 3.4 million, less 424K in the non-operating, 497 of it was movement. So that's where you see that the expenses fluctuate, that $1 million difference is really us moving cash in and out of expense accounts or revenue accounts and into the balance sheet where it belongs.
Okay, the grants.
Yes, it is 100% grants.
Okay.
Slide. So we're gonna look at the year-to-date through August, total revenue is 6.8, less operating expenses 6.7, plus the non-operating of 109. So that's where you see the big movement in the grants and some of the other fields that true it up.
So in our next reports, we won't be seeing grant revenue expense. That will be a balance sheet item, correct?
Correct. And the reason it isn't shown here is because we've already submitted these to the auditors and the bank, and we gotta wait for them to
Okay.
give us their blessing. But if you look at the lowest line there, the normalized was 384 positive in July and negative 226 in August, but still 159 positive for the year. So we're trying to diminish the noise.
Now, the grant revenue expense actually nets out to 10,000 for the year, which doesn't do too much move the needle, but it does move it from month to month.
Right, and you'll actually see some more miscellaneous revenue, 500,000, I think, in the month of September, so. But that one you would recognize immediately because it's provider relief.
It's not a grant.
Right, so, next slide. Okay, on the balance sheet, the thing I wanted to point out here is, because of this movement here in August and July, you'll see that the current liabilities actually go up, and that's because we're putting that into unearned revenue. That's the major movement here. As you go down with the fund balance, the 5275 versus the 4100. The 4100 is going to change in the next month or so. And that's just because we're taking and tying everything for year end. So you'll see a little fluctuation here, but nothing too drastic.
So when the auditors come with their adjustments, you're putting that in the previous year, correct?
Yes.
Okay.
Yes. But it'll affect this
Sure.
down the road, and I'll be able to explain it, and it won't be as wild as it was last year, for sure. Next slide. Okay, so this is the cash flow statement, and this is kind of what I just went for 6 months, and I just want to try to explain it as best I can so everybody understands it. Up at the very top, the first is the beginning cash in the operating account, which is unrestricted. You see patient collections as they go.
That's the net collections, correct?
Yes, because what actually ends up happening is I show the down below, correct. So you can see the 500, the 722, the 456, and then thankfully in October, 99. And
We're done with that.
Yes. Capital purchases, those are just estimates. But you see the net cash flow becomes positive in November and stays positive in December and I believe through June. But you'll see as the days cash on hand is 17 in August, 16 September, 16 in October, then it swings back up. And this is a really conservative estimate. There's at least 6 or 7 million in both accounts right now. So.
The tax receipts are the
Big kicker.
estimates from the county?
Yes.
Okay. So they took into consideration the reduction because of the pipeline?
I believe so. They're locked. I believe they're locked in based on that, based on the information we received from them. They're committed at that rate, as far as I know. And then you'll see the different debt service stuff as it stands right now. The grant restricted funds it's not it kind of skews this cash flow statement, so we took it out. And sure, other things that I can point out is like Lakeview Gardens, for example. You'll see that's the outflow expense, but we try to average it, but we're going to do better than the 220, 532. That's just based on the actuals.
So going forward, those are the estimates, but the actual is through August.
Yes,
Okay.
and they're improving every day. That's all I have for Lake Health District.
So you're still up with the Goose Lake Medical Services.
All right, so Lakeview Gardens gross revenue was 163, and the output was 48,774.
That's reflective of the shutdown for the...
Yes,
Okay.
and both houses are full with waiting lists. There's a $10,000 revenue deduction where, that Medicaid take back that we talked about last month was the $41,000. That was the true up for the year, where the hospital felt it this month, or in August. And Lakeview Gardens, it was done in July.
Okay. So we should see in September, the wages and benefits go down, or at least the contract labor go down.
Absolutely, and the thing to point out with contract labor here, the 116 and the 126, there's a $10,000 end of contract bonus for someone finishing their commitment for 3 years or 2 years. So that's why it went up a little. But if you think of the last quarter, the April, May, June, it was averaging about 275. So that's.
So when did we close that one in the middle of the unit? Was that in September? On that?
August.
That's why the wait, the
First part of August?
Yes, I believe the first or second week.
And for our constituents, we have a waiting list, but we don't have a staffing to, we open it.
Correct, and all, just to point out too, like all the administrative staff is actually working the floor and covering shifts.
Yeah.
So there's nobody holed up in an office. We changed the schedule too to make it more, so that we could stretch a little further with 12-hour shifts in long-term care. And that helps us cover gaps, and, the CNAs and all that, those programs are gonna save us in the end, do great things.
So in September, we'll see the wages and contract labor go down.
Yes, correct. And the other piece of that too is that 49,756 and other expenses in July, which is that provider tax. We don't have to pay that in October.
But that's a quarterly?
Quarterly, yes. But because our Medicaid percentage is higher than 85% right now.
But is this the first time this has ever happened?
Yep.
Is there any way to get this retroactive?
I went back through the last 4 quarters and it was like 84% or 82%, and we were just shy.
So are we full in both units? Then now?
Yes.
That means that we have 12 patients in the assisted living, 12 patients in the long-term care. It's the other 12-bed unit that we do not have. I'll talk a little bit about some of the opportunities for that.
Okay, and Lake Health Medical Supply for August, they did well, 51,000. That's percentage increase as well as their revenue deduction, so they're getting more efficient over there. As far as supplies go, they did have some back order stuff that came in and they invoiced. That's what that little bump in other expenses is. But they were net income of 15.6 for the month and 19.2 for the year.
Just need to multiply that by 10.
Yes. If we could get California to pay correctly, we would do that.
Any questions? Okay. Moving on, a medical staff report on privileging.
So Dr. Chang, the way his schedule works, he tries to get it so that he's here during this week, but it doesn't always work that way. Dr. Bradbury's here this week, and Dr. Chain's here next week. So the medical staff met this month and approved the privileges for Dr. Joel Kloss. I don't know if we sent that out to you.
No.
I didn't. Okay, so sorry about that. Dr. Kloss is a physician in Klamath Falls. He is applying for emergency room coverage. And he will be covering us one weekend, I think, this month. The medical staff found him to be excellent in all of his credentials.
But he's going to be working on a regular schedule then?
Well, the regular schedule is tough. His wife is a physician and they have a little baby. So he can only come when she's not working on a weekend or time period. He practices, both practice in Klamath Falls, and he can come when she's not
We
covering.
hire them both and move them over.
Good idea.
It's a great idea if we could accomplish that.
We'll work on it.
But, you know, the more that we start and get residents and get people from Klamath to come here, greater the opportunity we have. And they learn more about what we've done. Dr. Kloss had been, he had done a rotation here, so he knew a little bit more about what we were like. So I would recommend, the medical staff recommends that the board approve the privileges for Dr. Kloss.
So moved. And I second.
Moved and seconded to approve the privileges for Dr. Joel Kloss. All in favor?
Aye.
Passes unanimously. Okay. Tori, you're up.
Thank you. So I'm passing out our patient satisfaction scores right now for the last quarter three. So happy to say that our scores are mostly improving.
Did you all get this in the mail?
Yes.
You did?
Good.
Okay.
Just making sure.
Good.
So we're finally getting, in the 3/4, we're getting to the point where we're actually going to be able to count on those numbers for the year to date, where it becomes statistically valid,
Yes.
okay?
Yes. So we have the one outlier, the quiet at night. And thinking about what's up with that, I think we've had some patients who are very high fall risk and tend to be more active at night than during the day. So they trigger their alarms that clue us in that they're trying to get out of bed or trying to get out of a chair or something like that. And in part because of our higher census, especially in the OB department these last few weeks at the end of September. There's been a lot going on, so I don't like that number, but hoping we can see that go back up quickly.
So are you able to go back and see what times when that score came in and see what's going on then or anything?
Yeah, I can look at that. That's a good idea. Thank you.
Isn't that Alina, does she give you the metrics on that?
I'm sorry?
Alina?
Yes, yes, Alina can.
Yeah.
Yes,
okay.
thank you.
I was hoping I was.
Otherwise, over on the hospital side, like I said, census is up in all areas, ER and OB for sure, and acute, inpatient between beds. And I just want to point out that last week, the staff helped deliver 7 babies. We did 4 C-sections and 3 natural births. And so big kudos to the acute staff and the providers and the surgery staff, because that really put them through the ringer. But it was a huge success. And I think
Congratulations on a great quarter. I mean, most of the boxes are green. I mean,
That looks great.
Yes, thank you very
Good
much.
job.
That's what I have. Unless you have any other questions.
How are we doing staff-wise? Are you hiring? Are you?
I'm on the search. We've hired a full-time CNA, and from the CNA program, the last one that we did, and we have made an offer to one of our travelers who wants to convert to full-time night shift. So she's been eager to get in, so I'm confident that that'll go through, so that's great. Staffing's a little bit of a challenge. We are down to one traveler who will finish up this week, so it's kind of been a little tenuous day by day. How are we gonna work this out? But the staff really have stepped up as needed, and I've been real pleased with them. We're trying to keep the census as predictable as possible, though that's a complete, there's no way to control it really, but we do the best we can, so.
So what is the staffing per inpatient?
On days, ideal staffing is 6 nurses and 2 CNAs, and at night it's 5 nurses and 2 CNAs. I'd say right now, we're running a nurse short on every shift, but that's still doable. The way I had set the matrix up, the charge nurse, the leader for the shift, ideally didn't take a patient load, so now they are.
Yep.
But still going okay.
Thank you, Director.
Thank you.
Okay. With that, any other questions? None? CEO report.
I thought we would talk a little bit about 911.
That was the next You skipped over.
Skip D.
Oh,
Skip me, Donnie.
I'm looking at the one that was sent to me. So,
Sorry
the one
about
that
that.
was presented here, let's go to 911 first.
Well, I brought it up just so all of us be on the same page.
Okay.
I've had Mayor talk to me about what hospital and ambulance services doing, contributing, and I had other people, so I thought I couldn't answer it. So we just make sure we don't have scuttlebutt going in the wrong directions and have one clear understanding of what's going on with 911, so I'll turn it to Charlie.
So a couple things that I know, I have not been on all the conversations. About a year and a half ago, I met, I think Tyson was just brand new here. And we met with the town to talk about the issues with 911 and that service. And at that time, there was a lot of questions about how should 911 charge for that service.
So right now, the town of Lakeview runs it, is that correct?
So that the town has the contract to deliver the 911 service in this area. And it is operated by the town. The town has the employees, and we are based out of the fire department, that building. And they had the dispatch is what it's called. And so if someone calls 911, then they'll tone out either to the ambulance service or the fire department or the sheriff's department. They also, when they asked us, well, now that the hospital is in charge of this ambulance service area, they said, well, gee, we do have to pay for more of the cost of 911. And we talked about how many calls are there? And then how would we distribute the costs? At that time, and still today, it's hard for the town to define exactly how the counting of calls occurs. Yes, sir.
How much did the county pay before?
I don't know that answer. And as the town, Michelle Perry, has been working on this, there's a little bit of uncertainty. I don't know if it's zero or if they paid something.
In county? Yes.
How much the county did pay through the sheriff's department? I don't
Well,
know.
when I first came on, the county was only paying $20,000 per sheriff.
Per year, per year.
And county, in my opinion, is the ultimate responsible party for safety.
Sure.
But since then, we got new commissioners. Well, by the time I was leaving, the sheriff bumped it up to 70 thereabouts. And I understand that the county had bumped it up maybe close to 70 also.
So, what we found, our first response is, well, everybody ought to pay their fair share. That would be normal, and that would be reasonable. Based on the information they had on the numbers of calls, about 75 to 80% are either from the sheriff's department or from law enforcement, so it could be Oregon Highway Patrol. The others were interspersed between fire departments and then some of the ambulance calls. And we had a percentage of what we thought that might be. It gets to be hard when, is it considered one call if someone dials 911 and then the dispatch calls different agencies? How do they count them? And then it could be that one call counts for 5 calls, or one call, and one call, 911 in, one call to the location. So that there was, in my understanding, lack of clarity on the total number of calls, how you would measure it. This past spring, there was, it was recommended by the town that they form a intergovernmental agency that would be made up of representatives from all of the organizations that provide service based on 911. And this intergovernmental agency would then be responsible for setting the way it would run, how the calls would be handled, and it would charge various organizations for that service. It was my recommendation that our position would be, I don't think that's a good idea. And the reason for it is, a freestanding intergovernmental agency, when you hire people, you'd have to buy insurance just for a few number of people. You'd have to buy retirement plans and all the infrastructure to work that small organization. And so Tyson, on my behalf, went and talked with the group about this. And the last conversation that he was a part of, as a group, they all agreed that it would not make sense to form a separate company, an intergovernmental agreement agency, but rather it ought to be under one house. And it appears that that would be the county. I'm not sure if the county has agreed to that completely, but they're in the process of trying to establish responsibilities and then how you would charge the various entities. It gets to be challenging when you have an agency like Paisley Ambulance or Paisley Fire that may only have a dozen or under 50 calls in a year, and they're all volunteers, so how do they generate enough money to pay for that 911 service? So what we had talked about was that there would be a floor where a certain number of calls in a year they would not pay. Above that, other organizations would pay. We did put in our budget an estimated amount because we anticipated there would be some cost to the district for those 911 calls, should that become a reality in this fiscal year. But we don't know what that is. We guessed at what the amount would be based on roughly what we thought our number of calls to our ambulance service would be, and then approximately what the cost would be. There is an overwhelming issue in that the town is facing having to significantly upgrade its equipment, which is why they're saying we can't quite do this.
Is there a software or something that's antiquated that you have? Yes.
So there's newer equipment, newer software that GPS focused. And so if someone calls in on a cell phone and they don't know exactly where where they're located, while residents may know what mile marker they're at or what turn off or what's somebody's house, some of this equipment will be able to GPS articulate where it is. And so that's really helpful. And the equipment, over time, the computers age out and need to be replaced. So it's my understanding it's in the $700,000-800,000 of an expenditure.
Charlie, what size of a budget do they operate under? Have any ideas?
Well, Ken just kind of mentioned earlier.
The town said it was roughly $500,000, but I'm not sure if they were clear on how well it was clearly articulated.
Okay.
And some of that did not include the replacement. It had labor cost. It was commingled in part, as I recall. I don't remember it exactly. It was very close to some of the fire costs, because when dispatch people are working, if there's a fire call, they may be asked to go on fire leave. And so you get a lot of overlap, and that's becoming more and more of an issue.
So is Tyson and these other groups, the sheriff and the fire department, are they still having meetings with commissioners to work through this, or?
I'm not sure if it's just with the commissioners or if it's with the agencies that are all impacted by this to try and come up with a plan. That's the last that I know.
The last thing I heard several days ago is they met last week sometime, and basically so that both ends of the county can come. And everybody of that group, everybody agreed that the sheriff department of the county would take it over, but the sheriff would operate it. But that's still yet to go in front of the county commissioners to say thumbs up, thumbs down.
At present, it is still the town of Lakeview's responsibility.
Yeah.
And they are continuing to provide that service.
Back years ago, before I came, the town used to have to operate 911 in the fire department for the town. And then the state, this is back in the 70s, the state said, county, you guys need to step up and ensure 911 across the county. So the county contracted with the town to provide an added service out beyond. As long as we're all on the same page, that's get by different people asking.
Do you have any suggestions that we would take a different approach?
Well, I think it makes sense to allocate based on where the usage is coming from.
So it's an accounting problem.
I think in many ways, the allocation based on users makes sense. And that there are some users that are, it's unreasonable to ask them to pay what they don't have a lot of, and they're working on.
Like Thomas Creek West Side Fire Department. So I like that idea if you get X number of calls per year without a fee. I think that's a good way to go.
Like the fire departments in Silver Lake, Christmas Valley, the ambulance services, and both, they don't pay anything at this time, but those are actually underneath, in a sense, underneath county jurisdiction. But they don't have the money to pay.
Well, it sounds like too that in addition to, I mean, depending on what this upgrade to this new software and stuff, we don't know what the budget or the request or what the ask is yet.
Well, there's two things, capital to get it better, and then staffing, and then how do you track it, and how do you manage that? And there's just a lot that it is still, in my mind, it is still unclear. But it's reasonable to assume that the health district would be paying a portion based on the calls that we get for ambulance service. And of course, if there's a car accident or a motor vehicle accident, and the police are called and the ambulance is called,
Well, the fire department.
Fire
and the fire department,
Yeah.
so you have a lot of, and so how do you count that? And how do you say who's responsible? So it isn't just a simple cut and dry, but you want to create a fairness. And but the important part was, I was strongly against having an independent entity, even though it's an intergovernmental agreement, because while you have lots of input, you have very little way of managing that small service.
Makes sense.
Okay. Ken, does that address the issue?
Okay.
Now, before I start, I'd like to see if Lisa wants to make any comments.
So the clinic continues to do well. I think we have grown as far as we can with the number of providers and mid-levels and staff that we have. We changed the way that we schedule patients so that they are seeing more patients in a day, maybe 3 established care, which would be the hour-long appointments, the rest are half-hour appointments. So we are fitting as many patients in per day as we can. Again, if we want to grow more, we need to find some mid-level and provider help. Our travelers, like Dr. Chen and Dr. Chiago, are adding full schedules, 15, 16, 17 patients a day. So they're making a difference as well, but we need more.
So are we able to keep up in the walk-in clinic? Are we having long waits or? how-
No, they're not terribly long. Tiffany's pretty efficient. There was one day that, yeah, we ran a little behind because she saw 29 or 30 patients that day. So she is hopping. But we're doing the best we can. Like I said, the clinic staff is phenomenal. They're pitching in because we're short-staffed on key positions there. And we're short on providers, and they're tough to come by. So until we resolve that, we're seeing, you know, as many patients as we possibly can. And we still have probably 400 community members that need primary care physicians.
So as we're checking people in, we're getting the proper documentation and paperwork up front
Yep,
so that the billing process starts correctly from the get-go.
absolutely. The other piece that we implemented, and I can't remember if I talked about it before, is we have 2 clinic billers dedicated to the clinic. One is remote and one is on site. And it makes a huge difference because we have that connection right there. We don't have to depend on someone to come down from the hospital to help our patients understand their bills or help me understand why we're not getting paid for something.
Right.
So it makes it a lot more efficient.
Okay. The computers are pretty unforgiving if you don't do it right going in.
Yeah, and our patients, we have them now where they come in a half an hour before their visit with the doctor, so that we have time to get all of that information, so that as the revenue stream starts with our receptionists, there are less likely to be mistakes down. So that's working. Some grumble about it. I know their time's valuable, but we need to take care of their care goals, get their vitals, get their insurance information. So I'm really proud of the team. They've really
Because, you know,
stepped up.
open enrollment season is coming, everybody's going to change.
Absolutely.
Okay. Be prepared.
Oh, always. 37 years, I'm prepared.
Okay.
Thank you, Lisa.
You're welcome.
Kim, is there anything you would like to talk about? Or just listen?
I just wanted to mention that we submitted the 5-year reaccreditation paperwork to the AASM for the sleep lab. It's been 5 years since we became accredited, so, and I got green lights on everything that was submitted, and so we're just waiting to hear back on any fixes that we may need to have, but I don't anticipate any issues.
You're Rip Van Winkle.
We are hoping to work on some issues with the California patients, with traveling and getting here. Seems to be a little bit of a snafu sometimes, but our sleep lab has been full. We've got, 2 patients scheduled tonight. COVID, of course, they need to be tested prior to their sleep test. So we've had a few of those test positive recently, so we've had to reschedule those. But we're full staff ahead on the sleep lab. And we have a new respiratory therapist in the pulmonary and cardiac rehab with many years of experience, and he's ready to ramp up our rehab. So we're going to be working with care management and trying to get those patients from the ER and inpatients, when we have patients that are that qualify for rehab, to get them into pulmonary and cardiac rehab so they don't fall through the cracks, so we can start helping them improve their lives and get healthy so they're not making it back into the ER. On the respiratory side, we're short-staffed, so I've got 2 hats, but things are going well, and Tori and her team, the nurses, and we work well together, so it's going well.
Great.
Yeah, thank you.
Mike, good reports.
Yeah.
And Shirley
Shirley, yeah, I was
is
gonna
here
ask.
now. Shirley, why don't you tell, if you would, the board a little bit about who you are, and since you've been here now,
9 days.
She's
Today
got
is
it all
day
figured
9.
out.
Yes, not that I'm counting or anything like that. I'm really excited and honored to be here. So my name is Shirley Krantz, and I have lived in Klamath Falls for the last year. Prior to that, I was in Southern California. I was in Hawaii
Oh,
prior to that, and in the Bay Area. But the home base for me was always Southern California. My background, I've pretty much worked in all areas except for government and Department of Education. So, and I have no desire to do either of those. But at the end of the day, I have health care. So I have worked for a residential care facility for the elderly, the Masons. So they have 2 homes in California. So I was part of that team for about 6 years. I worked for a federally qualified health center in Kona. So they had 7 locations, behavioral health, dental, and then family practice. So it was a very big clinic on the west side of the Big Island. And then in Klamath Falls, I was working at the Klamath Orthopedic Clinic. So working very closely with those orthopedic surgeons in Sky Lakes. Background, I pride myself as a generalist, so I can do a lot of things in human resources. So just coming in here, I really want to support, bringing in physicians, nurses, staff, and then just even the onboarding process. So I'm just getting myself acclimated and very excited to be here.
Welcome to Lake.
Thank you.
Yes, good to have you.
do you expect a doctor and 3 nurses tomorrow?
Done.
Okay.
Absolutely.
Don, please don't scare people.
It's too late.
Do you want me to give them a credentialing update for you?
Would you please?
Okay. Been working, remotely for the credentialing. Kelly and I have done really well on getting pretty much almost all of the wellness is up and credentialed right now. So that was for wellness. So behavioral health and wellness is pretty much all their providers are up and running. Currently, I've got 8 of our current providers, like our MDs and some nurse practitioners that are going through our re-credentialing here. And once they're done, then I can take their applications, the Oregon practitioners credentialing application. And then once we have those, it's like there's like about 9 of them that need that form. So the size I'm getting those, I'm sending them through. So you're getting like your Providence, your probably about 9 of your big insurance companies that we're re-credentialing them through. Because Kelly and I have basically audited all of the insurance companies that Blanca gave us a list of, and we've asked them for rosters. Who do you have showing as being providers? And that's where we found a pretty big deficiency. And so now it's like we're going through and having to get them all added on. So we're just pushing them through as fast as we can.
So how often do you have to do that? I mean, once you get somebody credentialed, do they fall off in a year, or?
Some of them go for 2 years, some are 3, some are 5. So it just depends, and some of them have never been on them, so we're trying to get them on where there's like a list that we send originally to, like the EOCCOs, the Medicare, Medicaid, we do the reassignments on those, but just getting them their credentialing their applications over and getting them on everything. There's been a deficiency getting them there, so we're pretty much on a lot of these starting like
So you have a
completely.
paper file and a checklist when somebody comes up for credentialing, they're notifying a month or 2 earlier?
They give us 30 days notice to re-credential somebody or revalidate their credentials through the insurance company.
The insurance company
Who sends us the
notifies
information.
But do we have a fallback to know
We,
without relying on the insurance company?
not
because
previously.
They may not be reliable.
not previously, but we are actually, as we're sending them through, we're getting documentation dates of when they were approved. So we do have that now, but it's
Okay.
a new spreadsheet that we've started. And then we're looking at the credential stream software that we have, that we do all the credentialing in,
Okay.
there is a payer contract section in there, and Kelly and I are learning how to start putting them in there, so we can get the notifications automatically through our software system telling us
Your
when
own
we.
system.
So is this through Cerner?
No, this is through Verity, it's Credential Stream, we share that software system with Harney and Wallowa. Wallowa's right, yeah. So that's where we do their original credentialing and privileges and stuff like that through that software system, instead of the old paper files.
So when you see, when we bring the files of physicians or nurse practitioners to you for review, historically, the only people that needed to evaluate the credentials of a practitioner was the hospital. What's happened is the insurance companies now have very quickly transitioned to where they go through the exact same or very similar process of credentialing every single practitioner. And if they don't think that person's qualified, even though they're qualified at the hospital, they won't pay for that service. So what we did a couple of years ago is we bought the software. It's very expensive software to do this. Shared the cost with Harney and Enterprise, and have been using this. It's unbelievably difficult. And it's just another reason why insurance companies can say, no, I'm not going to pay for it.
Right.
So in order to make sure that we get paid for the service we deliver, we have to jump through the hoops, and we've got to stay on top of it. And they've been doing a great job.
Looks like they're doing the jump rope thing.
It is, and it's like Charlie was saying, it's the Oregon Practitioner Credentialing Application, which is a 15-page document that they have to go through and do all this assessments and stuff. But they're also required that, they require their medical license, their DEAs, their copy of their, malpractice insurance cover sheets. I mean, just like everything we have to do to get them here, is we have to send the same stuff over to them. And it's been, so it's not an easy thing. Plus, that if they've been around or they've been with them for a while, then we have to get copies of their CMEs to go with all of that stuff. And it doesn't matter if they're credentialed the first time or if we're re-credentialing, because they have to have the same stuff the second time. So we're getting the files updated online so that it's an easier process to do that, but it's been a matter of just getting it done.
This is a main part of improving the revenue capture.
Yeah.
What we found was a lot of the providers were not credentialed in certain insurances. They might have one provider in Blue Cross Blue Shield, one in EOCCO, instead of credentialing all of the providers in every insurance. So that's where Kelly and Susie are working hard to play catch up to make sure every one of our providers and both the hospital side and clinic side are all credentialed in these insurances.
Historically,
So there's a different credentialing for the hospital and.
Yeah.
Yes. Not only that, it used to be, if you were in the clinic, that we just paid the clinic. Now you have to credential every person within the clinic, even though the clinic is credentialed. Same thing with the emergency room. Everybody that goes in, we have to have the insurances credentialed just to work in the emergency room. It is, again, another way of slowing down the process of getting paid. But if we don't do it, we don't get paid. That's critical. So, anyway.
Once we give them the paperwork, it could be,
3 to 6 months.
Some of them we've gotten as early as a couple months, but it does take 3 to 6 months, so we can bring it and get them all paperwork, and then we sit and wait. And then sometimes we're like going, they give us, okay, if everything went through now, say we just got approval now for someone that we submitted 6 months ago, they give us a start date now of this, we're like, you're going back to the date we first submitted full
I was
application.
going to ask.
So
How the
some of them
reimbursement goes, it goes retroactive, right?
some of them we've been successful that where they'll go back to that date. Some of them where if they dropped off and there was like a gap in their credentialing, some we've been able to go back a year and a half on. And some of them were like, nope, this is the date, you're gonna have that date forward. So it doesn't matter how many people you solve for, they're hard lines. But
So
we
rather than getting
push
into the weeds
everybody.
too much, as you can tell, it just, it always amp up of what we have
Seems
to
to be a
do.
hot button issue, huh?
But it's the biggest thing, it's just that's how you get the money and that's how you keep the doors open is by making sure everybody's on there and it's, you know, we're trying as fast as we can, but we're at their mercy, we can get them the application. But then it's one of those things where if they take 6 months, then the application date, it has to be within 4 months of the application date. So I can send them the Oregon Practitioner license, you know, the application, and if it's now 6 months before they do it, I have to have it re-signed again because it's now outdated. So, and then trying to track those providers down saying, hey, can you just initial and sign and redate this for me? It's like, it's not our fault, we got everything in time, but they take longer. So it's, but you have to jump the hoops, and we're trying to jump the hoops as nice as we can, and we're getting it filled out.
Thank you.
So we're
Perfect.
pushing it.
Well, thank you for your persistence, and keep it up. Keep it up, yeah. Okay.
So I'll jump into a couple things that are going on. Number one, we did receive from the state $500,000 that they had talked about giving to us in May, June, July, August, but we did get it in September. So that was a very positive thing for us. And the good news is the legislature approved $40 million additional funds for dealing with the crisis that hospitals are facing right now to help with the backlog of patients that are sitting in hospitals.
Is this state or federal?
This is state. This is all state funds. $40 million to assist in that. Hopefully, what one of the components of that is that they will help with staffing costs. What the state has said is they can't do what FEMA did during the COVID crisis, which was pay for these travel agencies. The state says we don't have enough money to pay for that. So there's going to be a cost sharing. The organization pays a portion, the state pays a portion. So we're waiting to get the information on that so we could access that. And that potentially could allow us to open up the other house.
They haven't given you the allocation formula, how much the health district may get.
It's not going to be based on facility, it's going to be based on your capability. So if we can say, we could take on so many patients and here's what the cost would be, and we would share the cost, and it would be for some time period.
So we could open more swing beds and stuff then, potentially by doing that?
Right now, the money was earmarked for long-term care. Swing bed is in the hospitals. So right now, it doesn't appear that that is a component, although that is an alternative for the state to look at swing beds in critical access hospitals throughout the state. So there is multifaceted ways that the state is looking, both the Department of Human Services, DHS, and OHA, is looking at how they can partner to deal with. At present, there's over 500 people in a hospital somewhere in the state, vast majority in the large urban hospitals, that their acute component of their healthcare services is over. They could go to a long-term care, or they could go to a post-acute care rehab facility, or they could go to a foster home, or they could go to something other than going home, because they may not qualify or they may not be able to go home. But there are no beds. And there are no beds because, number one, they have transportation issues, or number two, they don't have staff at those facilities to provide the care for those patients. As you can imagine, not only do we suffer from staffing problems, so do long-term care facilities. So this is, but it's costing a great deal of money to both the state and to the large hospitals especially. So we're hoping that this will become more clear in the next couple of weeks, and we'll be able to access them. This summer, during fair, there were, and this past weekend, the mental health department did some fundraisers. One was the pie in the face, and yours truly was a recipient of that.
Didn't help your looks any.
Thank you very much.
But what was the flavor?
It was delicious. There were several of us that volunteered to experience that, and they raised a fair amount of money, as well as this past weekend, we had a comedian here to talk a little bit on recovery, that sort of thing. And we raised, I think it was about $4,000. So that was a really positive thing. And it was great for the community, great for lots of members in the community to participate and be involved. There are a couple things that are happening in the state that you might, I think I've sent you information that you need to know about. Oregon Health Authority has been the recipient of 2 large lawsuits that were filed. The first one was filed by 3 of the hospital systems in Portland, but it impacts all of the hospitals, especially us. And this is to have the state address the problem of lack of mental health beds and the appropriate place for them. As you can imagine, if someone does a heinous crime, before they can be judged, it has to be determined if they have a mental health condition. And so they're in a confined environment to protect them and the others. And if the state hospital doesn't have beds, they languish in acute care hospital beds. If that happens, that means that people that aren't having committed heinous crimes that need acute mental health services are unable to get into those beds. This is a state issue. And so that is one of the concerns that the state has been sued on to try and address. Second thing, so there was a law passed by the legislature in the last go around that addresses the requirement that any major merger of any sort would need to be reviewed by the Oregon Health Authority and others. What the Hospital Association has done is said that that is an unfair restriction on our ability to do business. And so there's some very clear legal reasons. A perfect example is occurring right now. The hospital in the Dalles, Mid-Columbia Medical Center, needs to replace its facility. It's estimated to be about $150 million, give or take. They didn't have the money, so they approached the Adventist system, and they're going to partner in or merge, or it's not clear exactly what will happen with that to me. That merger has to be reviewed and approved by the Oregon Health Authority. What the Oregon Hospital Association is saying is that's unreasonable. It's, number one, taking the decision away from business and how you deliver health care and putting it in the responsibility of an unelected but appointed people that work in the interest of the state, but not necessarily in the interest of the community. So those are 2 big things, and those were announced in the last day. So I want you to be aware of that. Partly because I serve on the board of the Hospital Association, but it also can potentially impact us. So we'll see how that goes. We've been talking about some of our grants from the state. We have 2 large grants. We've seen the money of a portion of that, of the $1.2 million for the BURN program. That's the Behavioral Health Resource Network. As a reminder, the state allocated 2 large tranches of money, $100 million in each tranche. And then they allocated each of the states, or counties, based on population, and homelessness was another component of it. For Lake County, it was roughly $1.2 million for the behavioral health resource network contract. And for the housing, it's roughly $1.4 million. Interestingly, while we signed the agreement, the money went to the county, that $1.4 million. They're trying to figure out how to change the agreement so that that doesn't come to the mental health department that we are administering. We need to spend that money by the end of December 2023. So that's, at one time it was 18 months, it's now 15 months, and the clock is ticking fast. So we're working on, the state hasn't even defined clearly what all the criteria are on doing this. Just this past week on the Behavioral Health Resource Network, the MERV grant, they have suggested that maybe the date to get moved from December of 2023 to December of 2025. In part because, as you can imagine, if we were to acquire a building and have to do remodeling and have that and start delivering services all within that 15-month time period, it's hard to find contractors to do the work. And this is a problem throughout the state, getting the work actually done. So we are right now, we'll be dealing with this in the next couple of days. Do we want to extend that agreement? Now, when we talk about the $1.4 million on housing, there's lots of definitions of what housing means. And at a recent report, one of the things they talked about was, how do you define what those housing needs mean? And there's actually 8 different criteria. I want to give you an idea of that. One is prevention. Those are people at risk. Another is emergency shelter. Another is transitional, then rapid rehousing, respite recovery, supportive, affordable, and market rate.
Do we have to meet the needs of all of these?
No. It is only dealing with supportive. So when we talk about, we did have a grant a while back that looked at finding, again, supportive housing. And the worry was that meant this was for homeless people. It's not exactly accurate. In fact, it's not true. People that are in a homeless situation, that would fit under the emergency shelter, because they don't have a place right now, and they're there for a very short time period. The supportive housing concept is that this would be, if you could imagine, a person who had a living situation where their crisis occurred, there was some abuse or something that wasn't acceptable. They moved out, they went into a crisis center. And now they are going to restart their lives, and they're going to stay in a place. And they may have an addiction, and they want to try to stay safe in that environment. We want to help them stay sober. They may be there for 6 months. They may be there for a year or 2 years. But that is not their permanent resort, and it is not their crisis center. So it's a rebuilding. That's the kind of facility we are asked to develop. And the state is asking throughout the state, all the counties to work on this.
But not only to find the facility, but then we have to staff it and run it.
So part of the grant deals with several things. Number one is planning, finding the right place, making sure that you involve lots of community partners, talking about this, then acquiring something, whether it's renting it, buying it, and fixing it up, whatever condition needs, and then hiring staff to provide services to people that use that facility. So it's a combination of several different things. The next part is this a one-time grant, or is it a continuing funding program?
Because once you hire staff, you got,
That's correct.
that's forever.
So, the answer is the state is working on the financing from the legislature, because that's where the money comes from. And that hasn't been completed. So we can't just willy-nilly go and do things. We need to be thoughtful. and we have a short time.
So I think I should cut for the worst of it. You're asking us to put something together and then say we weren't sure how we're going to fund it.
And I think it's also a challenge in that, by and large, the mental health units and services throughout each of the counties are in the business of providing mental health services, not in the business of providing housing or providing other services on top. So it's a mixed match. So from a Lake County standpoint, remember, we not only have Lake View, but we have North Lake, and we have Paisley, and we have a relatively bifurcated county, and there's a lot of distance between them. So we need to be thoughtful about all of this. So we're working, but that's kind of what we have.
What happens if we don't take the money?
We have taken money. Because the money was allocated to all counties.
The county has money.
Well, we have a portion of it, not 100%. There's a process of sending us some of that money. But the state wants the counties to do this. And so they want us to find ways to figure this out. So the plane's taken off and we're working on the wheels. That's essentially what we're doing. And it's happening throughout the state. So,
Now, if we went down a road of supportive housing, that would or would not be a branch of mental health program? It would not?
so to answer your question, a portion of it fits within our responsibility of delivering care, where therapists are providing that service. We would, under this grant, be adding additional people to provide that service, over and above what we're currently doing. At this point, what the state has said is that we would be the owner of that structure, that building, or on the hook for the rental. So there's still some parts about who would manage that, and you don't want to be the same group that rents to someone and the other person that says you don't pay your rent. You want one person to be, or one organization to be responsible to do all the arrangements with renting the facility and making sure people pay their rent. The other part saying, we understand your challenges and we want to help you. Sometimes there's a conflict. So we need to be clear, and we have to establish relationships with others to help us with it. So we're going about this in a thoughtful fashion, and we have to do it fast, amongst other things. Tori didn't talk about our staffing survey, but we were audited by the state to look at, to ensure that we are staffing our organization per the state regulations. And we're working on a response that is, I think the first survey that we had, it took us 6 responses to get it right, 5 or 6. Because after all, they're very, very particular. And some of the issues they raised, we take umbrage with. So we're working on a response. We'll get that.
The state agencies don't have a staffing program.
Not as much as we would sometimes like them to have, but we'll work on that.
Just a side note.
I was hoping to have for you the applications from the nurses that have signed, have started their class on loans. The 2 nurses that have started have elected not to ask for grants. So it tells me one of 2 things. Either it wasn't the right deal, or we need to rethink how they're offering those. But they chose not to. So I do not have any applications to present. Other than that, it's just regular. Does anyone have any questions on anything I could answer?
Did we get the ambulance deal with the disaster unit taken care of, or are we still working on that?
We are working through a finance company to see if we can find we're providing them with information about our financial ability to pay. So we're going through that. Sometimes they ask for us to use the vehicle a little bit more and borrow a little bit more than we were planning to make it worth their while. So the threshold is a little higher. So finding the right things that fit that. We thought we could have it done in September. Well, we didn't. We have explained that situation to the disaster unit members, and they are understanding. Okay. Other questions?
Anything else?
No.
Other than that,
With that, we'll adjourn to executive session under ORS 192-616, bracket 2, bracket A personnel, bracket C medical staff, bracket D real estate, and bracket H legal. And will be the board staying.